Great. Good evening, everybody. My name is Mignon McCulloch, and I'm here with Beira Rousseau, and we're going to hand over to Haroon Saloojee, who's going to be chairing this meeting. Thank you, everybody, for your patience. I'm sorry we didn't expect this many people to join us, but it really is good news. And Haroon, over to you.
All right, well, good afternoon, everybody, and welcome to the fourth SAPA meeting. We're obviously delighted that there are so many people joining. Can I please ask that everybody mute themselves, and also please stop your video. We only want the panelists to have their videos on. So can I please ask everyone to go to the bottom and actually stop the video? If only the panelists should have video. Thank you very much. All right, so let's, without much ado, get going with this session. I think everybody knows why we're having the session today. It was organized at relatively short notice, but it's such a topical issue, the whole issue of should children be going back to school. Our panelists today are three distinguished pediatricians. Firstly, Professor Shabir Madhi, who I think many of us know, Professor of Vaccinology at WITS, and he's been the go-to person in the media. If the media wants any comment on COVID, he's been the guy they've got hold of. So we're delighted that Shabir's joined us. Our second panelist is Dr. Fiona Kritzinger. And Fiona is a pediatric pulmonologist based at the Christian Barnard Memorial Hospital in Cape Town. And then our final panelist is Dr. Archary, who's an infectious disease specialist at Durban. So the way we're going to do this session is a little bit different from some of the previous sessions. We're not going to have formal presentations from each of the panelists. Instead, I will be raising a number of questions to them, usually first a primary person, and then I will ask the other two panelists to comment on it. Okay, so without much ado, let's get on with the session. We know why this issue is so controversial, because everybody's got a view and the views are so different. So our Minister of Education, Angie Moseneke, wants children to be back, certainly the grade 7s and 12s by the 1st of June. The unions are ready to go to court because they're saying it's not safe to be there. The parents are very unsure. A survey by the ENCA last week suggested that only 25% of parents wanted their children to go to school. The other 25%, 50%. Finally, lots of organizations like Equal Education and others are also saying unless the situation is safe, our children shouldn't get to school. So here's the first question. Can I again ask that anyone who's not a panelist, please mute your mic. So the first question goes to Shabir, Professor Madhi.
Haroon,
Yes.
it's me on here. I'm just going to mute everybody, and then can the speakers please unmute themselves, okay?
Fantastic, thank you. So Professor Madhi, the first question is to you. And it's this whole question of what do we know about children? How infectious are they? And if they go to school, what's going to happen? Shabir, can you?
So thanks, Haroon. So Haroon, I think if you allow me, I think we need to take a step back. And unfortunately, much of the concern and anxiety sort of speaks to the need for a demystification of what to actually expect with this virus. Now, there's no getting away from the reality that people are going to get infected with this virus. Whether we have a lockdown, level 5 lockdown, or level 2, or level 1, or level 3 lockdown, people are going to get infected, both children as well as adults. The important issue is not about people getting infected, it's about the rate of infection that takes place, right? And that will determine just exactly what sort of consequences are going to be suffered in the country at the macro level. Right. So the first thing that we need to understand is that this is a respiratory virus. And like every other respiratory virus that comes each year, right? Roughly about 1/3 of the population are infected each year with influenza. When it comes to RSV, 2/3 of children will be infected each year with RSV. This is a respiratory virus. Its modality of transmission is similar to influenza, similar to RSV. So the notion that we can protect and prevent people getting infected, unfortunately, is an unfounded notion. Right? What we need to work towards is ensuring that there's a slowing in terms of the rate of infection over a period of 2 to 3 years, unless we remain perpetually in level 5 lockdown, right? 2/3 of the population are going to get infected, right? And that 2/3 might be 1/3 this year, and then we're going to have a second wave and a third wave. So whatever decisions we make and whatever we're thinking about in terms of how to go about normalizing society needs to be done in a context that this is not a 2020 problem. We're not going to have a single wave and this virus is going to go away. That is not the reality. We're going to have multiple waves of this virus until there is herd immunity, where roughly about 2/3 of the population have been infected, or alternatively, we get a vaccine sooner than that. So I think that's an important starting point. Now, in relation to the direct answer to your question, so the first thing what we know, and this is studies that were done in China initially, is that in a household where there's one infected adult, the chances of a child being infected is exactly the same as a child being infected. So in Wuhan, where obviously there's fewer children per household than in South Africa as an example, when there's an infectious case in the household, there's a 6 to 8% risk of another member of that household being infected. And that risk is exactly the same between children and adults. The difference is that when children get infected, right, they're much less likely to become symptomatic, or even if they're symptomatic, they're more likely to have just a mild illness compared to adults. So adults that have become infected are more likely to be symptomatic, and depending on their age, depending on other comorbidities, they're more likely to develop severe disease. Right, so there are differences, but the risk of infection remains the same. Keeping children at home doesn't mean that they're not going to get infected. If those parents are going out to work, they are going to be the ones that are going to be infecting those children in the household. Right, so I think we need to look at it from a macro level. So when children get infected, what do we know? So just give me 1 second. So like I said, the big problem that we face is an issue of needing to demystify this virus. Right, and if I know this was not meant to be a presentation, but I'm going to share 1 or 2 slides just to illustrate 1 or 2 points. Okay, so you're seeing this here, and so this is just a background in terms of what I'm talking about. You take 1,000 adults, right? Over a 2-year period, what we expect to happen in that 1,000 adults, right, is roughly about 60% of people are going to get infected. 40% of people will remain susceptible. So that 60% of those that get infected, obviously 600. Now, of the 600 individuals that are going to get infected, the majority, between 50 to 80%, in this sort of schematic representation, 70% are going to be asymptomatic. They're never going to know that they were infected. Right, and that is happening right now in South Africa. When we do contact tracing, between 50 to 60% of people that are being sampled because the contacts of someone that's infected are completely asymptomatic, but they're actually infected. So 70% of all of the people that become symptomatic are going to be asymptomatic. Of the remaining ones that become ill, that have clinical symptoms, 85% of them, or 25% overall, will basically have a mild self-limiting illness, right? Very similar to a flu, maybe a bit more severe, but it's a mild self-limiting illness. What we then end up with is roughly about 5% of all of the people that are symptomatic ending up in hospital, and this is above the age of 18, right? And that's roughly about 26 out of 1,000 adults above the age of 18. And then roughly about 5 people might die. But that 5 people differs tremendously by age group. If you take a healthy age group of 18 to 45, you're not going to get any deaths. If you go above 65, rather than 5 people dying, you're going to get 10 people dying. Now, it's a very different story in children, right? And this is the reality. In 1,000 children, right, assuming children are equally susceptible to getting infected as adults, right, we're going to get roughly about 2/3 of the children that are infected, that are going to be infected. And that's 600 out of 1,000 children under the age of 18. When I'm talking of children now, I'm talking under the age of 18. Okay, of the ones that become symptomatic, of the ones that are infected, the majority again are going to be asymptomatic. 70 to 80% are going to be asymptomatic. Of the ones that develop an illness, unlike in adults, where there's about 26 out of 1,000 adults that might end up being hospitalized, in children, we'll be unfortunate if more than 1 to 2 children are actually hospitalized out of 1,000 children, right? And we'll be even less fortunate if there's 1 death out of 1,000 children. And I think this context is important because there's a lot of anxiety on the part of many people in terms of what risk are we exposing to children to right now. In reality, the risk that we are exposing children to right now is probably greater to their disadvantage by keeping them locked up at homes than allowing them to go back into schools. So,
right. So Shabir, let me come in there. Let me ask you some direct questions. The question I'm going to ask you is now the right time for children to go to school? But let me ask you some specific questions. Are children at less risk of getting the disease than adults?
They're equally likely to be infected. They're less likely to develop severe disease, but they're equally.
Okay, so that was the next question. So they're at equal risk, but they're less likely to develop severe illness. So is this the right time for children to be going to school?
Well, if you're going to keep the school shut now, then you're going to need to keep the school shut till the end of 2021 or 2022 until a vaccine becomes available. And that is a reality we need to face up to, right? That this problem is not going to go away in 3 to 6 months, right? Globally, there's a recognition that this is going to play out very similarly to the 1918 Spanish flu, when in fact the second wave of the pandemic was actually worse than the first wave of the pandemic. And the extent to which the second wave will compare to the first wave depends on the non-pharmaceutical interventions that we propose and how effective we are in terms of implementing. Now, we need to understand South Africa is not Singapore, South Africa is not New Zealand, South Africa is not Iceland, right? What allowed those countries to be able to contain the spread of the virus, right? Those realities do not exist in this country at a number of levels, which I'm not going to go into. Right, but even in those countries, we've seen in Singapore, we've seen in South Korea, right, that you need to have an ongoing heightened level of surveillance to identify those few cases that are going to emerge suddenly, right, even after you start lifting your lockdown, right? And those realities is difficult. It's impossible for us to try to aspire to what's been done in New Zealand or Singapore or South Korea. We are like the many other countries that need to live with the reality that this virus is with us. It's going to be with us at least for the next 2 to 3 years, or until a vaccine becomes available. So whatever planning we do, it has to be done in a context that this is not planning for 2 to 3 months. So we either open schools now, and we might need to close schools in a few months' time when there's a huge surge of number of cases, and there is going to be a much greater surge of number of cases, even in the Western Cape, than what exists today.
Right. Okay, Shabir. So I think I want to go back to the issue of school sync. That's our main discussion. I think everything you've said is quite important. So my concern is from what you're saying is that I'm worried that there's a lot of COVID around currently as a parent, that I'd rather send my child to school in a month's time when there's less COVID around and there may be less chance of transmission. What's wrong with my thinking like that?
Well, your big problem with your thinking is that in 2 months from now, we're going to have much more COVID than we've got right now. In fact, we might well need to close the schools around about the end of August, September, when we really get the surge in terms of the number of cases. So it's a decision that we need to make. We either open schools now, right, or we accept that there's not going to be any schooling this year. We can reassess early next year, but I'll be highly surprised if by March we end up better off than we are now, and if there aren't going to be continuous disruptions for the next 2 years.
Okay, so fine. I say I'll bite the bullet and I'll send my child to school next week. What can I expect? How likely is my child going to be infected?
Your child is probably slightly more likely to get infected than if the child stayed at home and you went to work but came back with the virus, because you're obviously in contact with more people. Right, but am I worried about it? The answer is I've got 2 children and I'm waiting to get them back into school, right? And the reason for that is not because I'm putting their health at risk, I'm putting their education at risk right now, right? And the reality is that when they get infected in school, I'm rest assured they're not going to develop a severe illness. For many of the children, right? The problem we face right now in South Africa is because of the level 5 lockdown and level 4 lockdown. What effectively happened in South Africa is that we've been highly successful in terms of not only delaying COVID and SARS coronavirus 2, we probably have also delayed RSV, right? So anyone that's in the practice right now, you know that the number of cases that you've seen of RSV this year, or wheezing or bronchiolitis, is about 80% less than you did last year and the previous year. And that's not because RSV has gone away. It's because we've interrupted the transmission of RSV by having the type of measures that we've put into place. So when children going back to school, they're going to be exposed to RSV, right? Because the community immunity to RSV has actually waned, and that's when RSV usually comes up. They're going to be exposed to influenza. They're going to be exposed to SARS coronavirus 2. Now remember, in China, at the peak in Wuhan province itself, at the peak of their epidemic in Wuhan, when they tested children that were hospitalized, there were more children, 5-fold more children that were being admitted to hospital for respiratory illness that was due to influenza than due to SARS coronavirus 2. Right, so these were children that were being admitted with LRTI, and this was right at the height of the Wuhan epidemic. So it tells us that children can get sick from SARS coronavirus 2. They develop COVID illness, right? But relative to the risk of developing illness from other respiratory pathogens, it's nominal.
Okay, Shabir, so here's the story. So you've convinced me maybe I should send my child, that my child might get COVID, but it's not going to be a serious illness. That's fine. But now the teachers don't want to be there. The teachers union are saying, we don't think it's safe to be there. And of course, there's a risk that the teachers are, the concern is that teachers are at higher risk. How much of a risk are the teachers at? Is it fair to ask teachers to teach my child?
Yeah, so there needs to be a risk profiling of the teaching constituency, right? And I'm not suggesting a 65-year-old teacher that's supposed to retire in a few months that's got hypertension and diabetes should go back to school. That would be irresponsible. So there needs to be a risk profiling. But at the same time, we also need to accept that if teachers were to adhere to the principles of NPIs, the non-pharmaceutical interventions, the social distancing, wearing a face mask, hand hygiene, if they were to adhere to that, right, they wouldn't be at any greater risk of being infected in a school compared to being infected outside of a school, right? What prevents people, what reduces your risk of being infected is not where you are, it's what your behavior is, right? And that applies to students, that applies to teachers, that applies to everyone else. It's about behavior that determines your risk of becoming infected, right? The virus is all around.
Okay, Shabir, so maybe you can stop sharing your screen so we can see our panelists' full face. I'm going to ask you one more question before I move on to Fiona. And the question is, okay, so that's teachers, but now children are going to go back home, and there's OPA there, and there's GOGO there. What about the risk to the family? Is that not enough of a reason not to send all these children to get infected at school?
So the short answer is, you made me take off my slide share, my slide. So you're going to
now just talk to each Shabir.
Yeah, so I mean, the short answer is the only data we've got, so there's limited data, okay? And I think that's the reality. But there is data from the Netherlands, which did a really good study, which basically looked at when there's a specific age group of individual that's actually infected in the household as an index case, right? And who is that person, not only in the household, but even more broadly, who is that person more likely to infect? And what they basically found is that it's a linear association. Right? Age-related linear association is that people in the same age group are more likely to infect others of that same age group, which doesn't come as a surprise because people of the same age group are more likely to interact with other people of the same age group. What they also showed is that adults are basically infecting adults, adults are infecting children, and children are rarely ever infecting adults. Okay, so what's the reason for that? Now, children don't just develop asymptomatic illness or have a mild illness because of some miracle. There's some underpinning issue in terms of their immunity, which allows them to be able to control the virus in such a manner that prevents them from developing severe disease. If their body is not able to control the virus, or there might be an issue in terms of the receptors that are required for the virus to cause severe disease. But if that's not in place, children, like we see with RSV and everything else, will develop severe disease. So what are the possible reasons? One of the possible reasons, right, is that we know if we go in a community right now in Soweto and we sample every child, healthy children in the community, between 12 to 15% of them are going to be infected with coronavirus, not SARS coronavirus 2. They're going to be infected with other coronaviruses that have been circulating since the 1960s, right? Is it possible that infection with those coronaviruses confers some level of cross protection against SARS coronavirus 2? And the answer to that is very likely, right? Especially when they belong to the same sort of family of coronaviruses. So that is one hypothesis. But the reality is that children don't develop severe disease, not because of some miracle of nature, but because there's some biological, some biology underpinning the reduced risk. And it's all related to the immune system, or that they might not have these ACE2 receptors, or they've got less ACE2 receptors than adults. Right? Now, by virtue of them not developing severe disease, by inference, it means they're able to contain the virus, right? And their viral load, so there aren't studies to look at what is a viral load between So when children are hospitalized, their viral load is the same as an adult's viral load that's hospitalized. But that's an incorrect comparison in terms of generalizing what happens in a community. Because the child is infected in a community that's got a mild illness and or asymptomatic, we don't know what that child's viral load is in relation to the child that's hospitalized. And in all likelihood, knowing what we're seeing, it's going to be lower. And that means they're less infectious.
All right, Shabir, so I'm going to hold you there and bring Fiona in. What I've heard you say is now is as good as any time to send our children to school, that teachers, if they do the basics right, are not at high risk of getting infected, and there isn't a major risk to everyone at home, including granny and grandpa. Fiona, do you agree with that view? Would you be as willing to send your child to school next week?
Yeah, well, if I read the literature, I completely agree with Shabir. I think the biggest risk for, primarily, the biggest fear for any parent.
Fiona, sorry, it's Mignon. Do you mind just speaking up a little bit so we can just hear you?
Sorry, can you hear me better now?
Not really.
Can you hear me better now?
Yeah, perfect. Thank you.
Okay. Now, I totally agree with Shabir. I mean, I'm not nearly as an expert as he is or know all the data that he does, but from the literature that I have read, I agree with everything that he has said, and I agree that schools should be reopened, and I agree that the vast majority of healthy children should return to school. I think the biggest fear for any parent is around death, ultimately, because that's the worst outcome for every parent. And again, I think it's important, as Shabir said, that we must put the data into a context so that parents and us can actually understand what it really means, because a number is just a number, but we have to, I believe, put it in a relative risk to what was the risk last year in June for a child to go back to school or to be in a school. You know, if you look at the US data, in the same period of the COVID now in America, there were 9 reported deaths related to COVID, but the total child mortality was 31,500 children died in the same period of time. So COVID contributed 0.03% to the deaths of the children in America. So I think that the sad thing is children do die each year, every day, of various reasons. And I do not think the risk for death for children this winter is higher than it was last winter. So I guess the question is there a group or is there some children that may fall in a different risk category to that generalized statement? And there the data is not very helpful. I mean, there is some data, but the comorbidities in children is much less clear and much less published as in adults. And probably because to begin with, we see so few children, or far less children than adults. And therefore, it's difficult to really tease out which underlying conditions is a risk factor. There is one study from the US that had laboratory confirmed cases, around 350 cases. And of them, a quarter of them had underlying conditions. And I don't think there's any surprises in that list. We are used to that list for many other viral respiratory illnesses, such as chronic lung disease, cardiovascular disease, immunosuppression, chronic kidney disease, liver disease, diabetes, and then neurological conditions. But again, I don't think there is anything surprising on that list. That's exactly the same children we would have been concerned about last winter for RSV or influenza.
And the one that's commonly asked is asthma. What about asthma?
Yeah, again, I mean, like any other asthma patient, that's such a common condition. But the long and the short is if your asthma is well controlled, your risk for a severe exacerbation when you get a rhinovirus or a RSV or influenza is obviously far less than when your asthma is not well controlled. Or if you have severe asthma and you're on high doses of medication to control your asthma, you might be more likely to have an asthma exacerbation. But I'm not sure that you necessarily have an increased risk for the type of interstitial pneumonitis that is associated with COVID. just because you have an airway disease doesn't make you more susceptible, I think, biologically for an interstitial pneumonitis. So I think there is a lot of this is based on assumptions that we've known about with influenza and RSV and adenovirus and rhinovirus. But I honestly don't think the data is out there that actually supports our gut feeling yet. But I think it's reasonable to assume that those children might be at higher risk. And so in those groups, I would suggest individualizing this.
So I'm going to welcome chat line questions. The question now is, what about cystic fibrosis?
Yeah, it's an interesting question. I mean, again, I haven't seen any specific publications, but what I have heard word by mouth from North American centers and European centers is that they actually haven't seen CF patients come in with COVID exacerbations. Even, big CF clinics like SickKids and in Toronto haven't had a single CF patient admitted with COVID.
Finally,
so
what about children attending special needs school? Any reason to be concerned there?
I think it comes down obviously to the behavior of the children and how the children are able to follow certain interventions. And it might be very difficult for them to wear a mask, for example, or necessarily to understand to keep to social distancing, but they can still wash their hands. And, so I don't think that from a point of view that they are at greater risk to develop severe infection. I don't think we have any data. They might, due to their behavior, like Shabir said, have a slightly higher risk for infection. But I don't think they have a higher risk for serious symptoms.
Okay, thanks, Fiona. So the list, there's a few more questions, but we're going to move on from this question. So there's questions about what about diabetes? What about previous heart condition? I think we must move on. I'm sure we can answer that at another time. Now, I'm not sure whether Dr. Archary is still with us because he had another teleconference. Mo, you still there? Can you take a question now? So Mo, the question is, and Shabir unfortunately is going to have to leave us in 10 minutes, but let me ask you this question. So it seems from the other two panelists that Tabos has to go to school next week. He's on his way. Now I'm worried. What do I have to do? And so we've had lots of questions. What kind of social distancing? What kind of mask? Is there a good mask to wear? What else must I do to make sure my child is safe? And then what does the school have to do to make sure that my child is actually going to be protected? What's your advice?
I think the things are, I think the first thing is to say that the difficulty is that there's no direct evidence in terms of interventions that work from specifically around COVID-19. However, we can look at other countries in terms of what they've implemented, in terms of the processes that they've gone about, in terms of keeping schools open and reopening of schools. So if you take the example of Sweden, and Sweden went the route of not closing schools at all. And they put into place quite simple measures to maintain the school functioning with very simple things to keep it going. And I'll go through some of the aspects that they did. So, and what they found at the end, it really didn't impact on the overall epidemic in terms of the numbers of infections that occurred. And even when they looked at the seroprevalence rates at the end of the epidemic, and they're coming to the end of it, the seroprevalence rates was about 6-point-something% in adults and about 4-point-something% in children. So really, this issue of children being, even if
but Mo, just to be argumentative, there's evidence of a school in Sweden where there were 500 children and 18 of the teachers out of a staff of 76 actually ended up with COVID. So that's one of the ones quoted about how teachers might be at risk. But anyway, that's just being argumentative. Let's get on to what you're suggesting the protection should be.
Okay, so I think the first thing is, I think one thing is to say that what are the things that we definitely know should not be recommended. So the things that should not be recommended is the issues of spray tunnels, human spraying, and there's enough evidence to show that this is harmful for children and increased risk of respiratory affectation, skin irritation, and eye irritation. So those fancy spray tunnels that some of the schools have put onto the media is really something that we should, as pediatricians, warn against in terms of being harmful for children, and surely should be discouraged. Similarly, environmental spraying hasn't been shown, and fogging of the environment really hasn't been shown to decrease transmission rates, and also there's contamination of the environment, and the disinfectants that are used in those sprays, often we don't know what are they, and they could be posing harm to children. So the things that we should be saying, the first thing and the most important thing is to prevent or not allow symptomatic individuals who are ill to enter the school system. And that includes both children and staff. And really,
and how would you do that, Mo? What does that mean? How would you exclude kids that you think are at risk?
So the difficulty is one issue is fever has quite a low positive predictive value. So if you look at the literature, only about 50% of the presenting symptom, as Shabir said, many children are asymptomatic. And certainly many of the symptoms don't occur in children. So the one thing that, and again from the Sweden model, was that if your child is in any way sick, do not send them to school.
Okay.
And I think that should be.
So Mo, let me ask you some more direct questions. So for those who are on the call, open the chat, because Professor Madhi is offering comments on some of the issues, so that I don't have to ask him that, but he's offering comments. So Mo, let's get on to the issue of the mask. So what's your sense of what kind of mask? And the fear of everyone is that children will not keep masks, particularly the younger kids. So what kind of a mask are you suggesting be used?
So the thing is, so the general rule of thumb is that we're suggesting the use of cloth masks. And particularly the reasoning behind that is actually it's to prevent the spread or contamination of the environment and limiting that. Certainly, I think the limitation is that, as many people have indicated, there is some lower age group at which that can't be used. And certainly, we're not expecting a 2-year-old to wear cloth mask. And there are alternatives, and the use of face shields are alternatives to the use of cloth masks. So the one thing is cloth masks for everyone, and particularly in areas where they are in close contact and closed environments. So in the school, in the classroom itself. And certainly, I think we're going to have to be slightly flexible to allow children to not use it when they in certain times of the day, because it does become restrictive over time. So I think working our way to try and see how we can best manage that situation, but particularly around.
So I'm going to call Shabir in just now, but tell us a little bit about social distancing. Everyone's kind of very worried that children are going to social distance. Is that possible? And does it matter if they don't social distance?
So I think the one thing in terms of social distancing is trying to limit the physical distancing issue in terms of how do you space the class out, and especially in closed environments. So certainly I think that you can do in a structured school environment where you can space the desks out, and the recommendation, although we've recommended 1.5 meters, the WHO is recommending 1 meter. So that can be done. The other thing is decreasing the opportunity to not social distance. And that comes from staggering of lunch breaks, staggering of other break times for children, and staggering the start and end time of school. So I think trying to be innovative in terms of trying to limit the times at which large numbers of children congregate in large numbers overall can go towards getting that social distancing program.
So Mo, one last question before I go back to Shabir. The minister has promised that there will be water available to schools. I'm not convinced that can be delivered by next week. So if there are schools without hand washing, children not to go back to those schools, or can we live with the fact that there may not be water at schools?
So I think certainly I think there does need to be facilities to do hand washing. If there's no facilities to hand wash, alternatives should be looked at, and the use of alcohol-based hand rubs is another alternative to that. But I think, certainly I think alcohol-based hand rubs is useful where there's not gross contamination of the hand, but certainly that both options should be available. And that's particularly pre and post going to the using the toilets, and also before eating should be one of the areas where we should be recommending hand washing as well. From our discussions with the Department of Basic Education, I think they've put into place many of the structures to get water available to as many schools as possible. So I think they seem to be quite confident that facilities for children to wash hands will be available for children.
Okay, Mo, so I recognize you need another call. Please stay on if you can, but I'm going to pass the baton on to Shabir. So Shabir, you've heard Mo's views. Is there anything you agree with? Is there something you want to stress that perhaps people have got wrong? I know you often find issue with things that sound obvious, but perhaps shouldn't be obvious.
Yeah, I mean, I agree with Mo, but I don't know, again, I mean, I think some of the comments on the chat group are really pertinent. And I mean, we need to move away from the idea. And the sooner we do so, the better for everyone, that we're going to prevent children from getting infected. Okay, we've never been able to prevent children from getting infected with RSV or influenza, which causes more children to die. Right, so let's just look at the numbers for what it is. Right now, of what's the number sitting at 300,000 people that have died, right? There's not more than, it's just less than 100 children that have died. In Italy, where there were 30,000 deaths on the 1st of May, there were 0 children that died. Okay, so children are going to get infected, and we need to accept they're going to get infected, and there's no getting away from it, whatever we do, right? It's just a matter of what is their risk of developing severe disease, and that is what needs to go out. Parents need to understand, physicians, healthcare workers need to understand that there is a nominal risk in terms of developing severe disease, and there's even a less risk in terms of dying. So unfortunately, when we get a 2-day-old child that's born to a mother that's COVID-19 that dies, right? Did that child die from COVID-19? We don't know. There were a whole lot of other things happening, right? If you, in New York as an example, when they randomly sampled all women that were delivering, right? They found that 15% of all of the women that were delivering were infected with SARS coronavirus 2. Out of that 15%, 85% of them were completely asymptomatic. Right, so mothers are on a daily basis being infected, and their children are going to be exposed to them knowingly or unknowingly. But we don't see large numbers of children anywhere in the world, young infants, neonates, actually dying from COVID-19, which means that there's something that's happening that's protecting children from developing severe disease. So if the starting point is we don't want our children to get infected, then like I said, keep the schools shut for the next 2 to 3 years. But that can't be the starting point of the discussion.
Okay, so this case, this is probably going to go to the court. So let's say this is the scenario that a school, there's 60 children per classroom, there's no water and sanitation, there's very little prospect of hand sanitizer, the taxi to school is going to be completely crowded. On your argument, you would say that's still fine. The kids must go to school because eventually they're going to get infected. And so let their education go. And if they get sick, that's fine. Are you willing to push it that far?
Yeah, there needs to be a risk-benefit analysis. And right now, that poor child in a rural area that's not going to school is being deprived of nutrition because he's not getting access to the food parcels that he should be getting each day. Right? So there needs to be a risk-benefit analysis. And what I'm arguing is right now, in terms of the risk-benefit analysis, children are being put at greater risk from a number of perspectives, right, than any sort of meaningful benefit by being kept at homes and by being deprived of immunization services, of food parcels, of education, and the list goes on, right? So there needs to be a meaningful risk-benefit analysis in terms of what it is and what are we trying to achieve. This is the first time where children are being protected, but we're actually harming children by actually keeping them back. We're actually punishing children, despite them not being at risk of developing severe illness, but we're punishing them in a number of ways.
Okay, so let's go to the other scenario. I've given you the worst scenario. The best scenario is I go to a private school. There are 15 children in school. I'm going to wear a mask. Is it meaningful? I mean, it makes sense. If you can prevent your child from being infected, that's great. Can I prevent my child from getting infected? Is it possible in the environment, both in school and outside, that I can somehow be among those children who after 2 years are still not infected? Because I really don't want even a mild disease in my child. Is that something that's feasible? I mean, I'm asking hypothetical questions.
It's feasible if you put your child in a bubble and keep the child in a bubble both at home as well as school. You might achieve that, but other than doing that, you're not going to achieve it. So children are going to get infected even if they're at home. If parents are going out to work, right? If there's other people that are coming to visit in that house, children are going to get infected, right? So there's no preventing people getting infected. There are opportunities in terms of reducing the risk of being infected, or preventing or sort of spreading out a period of time over which people will get infected. But there's no opportunity there's no resource that we've got available to us, other than to be at level 5 for the next 5 years, right, until a vaccine becomes available to prevent children from getting infected.
Okay, so I'm going to ask for you. So Shabir, Mo, you can look at some of the questions in the chat and perhaps take them if you want. There's anything that catches your eye. But Fiona, what would be your advice then to a parent, say, middle-class family going to a government school or a private school? How would you provide advice? What are you telling your parents and your patients?
Yeah, thanks for that question. Can you hear me?
Yes, we can.
Okay. Well, I'm telling all my parents that children without serious underlying comorbidities, and with serious, I mean they either have a serious immunodeficiency, a serious structural cardiac disease or lung disease that is not well controlled, or a chronic kidney disease or uncontrolled diabetes. I'm telling those people to be cautious, but I'm still telling them to, as Shabir suggested, you have to do a risk-benefit analysis for your household and your family. And you need to take that decision against the background of understanding that you're not making a decision for the next month or the next 2 months. You're making a decision at least for until the end of the year and early next year. And you have to look at, is it feasible and is it appropriate for your family and your household to keep that child locked up at home? And there are some of my families who say, well, you know, everything is sorted. The child is happy as Larry. We have homeschooling. We have all the facilities. Mom is at home overseeing the whole process. The child loves being at home, is in a good routine. Then great for you. Then maybe you're one of the lucky ones. But the vast majority of other people, their circumstances is such that either the child is actually not accessing appropriate education at home, or both parents have to work, or there isn't any serious underlying condition. And that, I believe, is the majority of households. And in that situation, again, if you weigh up risks to benefit, my question is, what is significantly different for the child this winter versus last winter? And if that risk was acceptable to you last winter, why is it not acceptable to you this winter? And in those households where there is really, really vulnerable people, and you want to try and keep the circle as close as possible, then I think we should also allow people to make that decision for themselves and not become draconic with our measures. But
okay, let me ask some general questions and then we'll try and wrap up. We've got about 10 more minutes, even though we started a bit late. But I know Professor Madhi. So any of the three of you can take these questions. So the first question would be, and Fiona, maybe you, because you've got the mic. What about sports at school?
yeah, again, I mean, I think it is a concern, because obviously the moment you have a group sport, there's going to not be social distancing. And maybe that's a big step for parents to make at this point in time. But I would argue that if you play tennis, and you can probably still play tennis with the opponent across the net, or if you do individual sports, it may still be able to do that. But I think for most parents, that's a bit of a stretch. But I would hope that physical activity, it may not be competitive sport, but that physical activity for children is definitely part of going back to school.
Okay,
again,
thanks, Fiona. Mo or
overall
Shabir, this question to you. So we open schools and we start finding that either the children or teachers have developed COVID, how big does the outbreak have to be before you start thinking we better close the school? Or is it something we say, it's going to happen, Shabir, your argument, school remains open, doesn't matter 10 kids or 50 kids got COVID, education goes on. From an epidemiological point of view, is there a critical number where we'll say, schools must close again? Shabir.
Yeah, so Haroon, before I answer that, just to, in terms of one of the issues that Fiona sort of mentioned, I think it's important to have extracurricular activities, but at the same time, I think it might be premature to introduce extracurricular activities immediately now. I think when going back to schools, there needs to be a rationalization in terms of the curricula and the amount of time that is going to be spent in school. And there needs to be minimization in terms of the possibility of close contact. So even during breaks, children shouldn't be gathering together and sharing lunch and kissing each other and hugging each other. So in fact, in the first 2 days of school, the only thing that should be taught to the students is about what this virus is all about and how can we protect ourselves. And hopefully the children become vectors of transmission of knowledge to their parents rather than vectors of transmission of the virus. So I think that's really important. So I think we need to be a bit guarded. I wouldn't say just open up the schools and allow things to be back to normal. So now I've forgotten the question you asked.
So what if there's an outbreak in the school? How will we define an outbreak in this kind of setting, and what will make us decide to close the school again? It's a theoretical question, but it's likely to happen, and it's something we're going to face. How would we approach this issue?
So I think Mo already mentioned that what we need to do is that even though there's a very low likelihood that a child that is symptomatic with respiratory illness, yes, actually got SARS coronavirus, is more likely to have influenza or RSV or rhinovirus. Those children shouldn't be going to school. So if a child is symptomatic, they shouldn't be going to school. And we need to be pragmatic. We can't be screening every child every second or third day. Neither can we do that amongst the teachers, right? And for me, I think the bigger risk in terms of there being an outbreak in a school is the behavior of the teachers rather than the behavior of the children. Right? The teachers are going to be the ones that are going to be introducing virus into the schools. And the behavior of teachers means that the teachers need to adhere to the NPIs. The teachers can't be gathering into tea rooms. They can't be gathering into staff meetings into a close in one little room, right? So it's really, for me, I think the critical issue at schooling, in fact, is the behavior of the teachers, because like Mo mentioned in Sweden, and you cited that example in Sweden, you had all of those teachers that were infected, but no children, right? So what does it tell us? It tells us is that the teachers that are infecting each other because of their behavior. Okay. So in terms of how to respond to an outbreak, we need to accept people are going to get infected in schools. Does that mean that we need to shut schools? Yes, we need to shut schools if we see a sudden dramatic change in terms of this epidemic and we end up seeing huge numbers of children that are hospitalized, right? Which is very unlikely to occur.
Okay, thanks, Shabir. So we're going to wrap up in about 3 minutes. Mo, I see you still there. I know you serve on the Ministerial Advisory Committee on COVID, and I know the committee is making recommendations about schooling. Is there anything that we've said today that hasn't been covered yet that would be part of those recommendations? You probably, well, I don't know whether you're able to share with us what exactly the guidelines say, but perhaps are there any things you want to highlight that's likely to come in and advise that you have advised the minister that hasn't been covered yet?
I think these are, so when we looked at the literature, again, I think these were largely based on what's the literature available. And certainly I think it's very clear that the likelihood of children having severe disease is extremely, extremely low. And the risks in terms of the issues that children have to bear with in terms of other issues that they have to receive with not going to school is far higher. So the recommendation is that children should return to school, and that should be done in a way that would protect both children, but also the school environment and teachers in it. And many of those protections that we spoke about, and what Shabir spoke about in terms of teachers, congregating and social distancing are included into that guideline. So I think the main thing is we want schools to be open because it's good for children. Secondly, we want to do it in a responsible way. And certainly I think the one thing is that I think there's a lot of anxiety that we need to accept, both in terms of parents and also children as well. And we need to take both the parents, children, and the community along with us as we get buy-in into return to school.
Thank you, Mo. I see there's one question that I haven't. It says something about national guidelines suggest screening of all learners and teachers twice a week. Is there any point in screening in the school setup? I'm not sure what these guidelines are. I haven't seen these.
So certainly, I think there's no. So I say there's a difference between screening and testing. So certainly, I think we're saying that you should be regularly screening yourself in terms of if you have symptoms of the disease, then you do not come into the school, and that really should be done, once a day. So every morning, a parent should be screening their child for symptoms, and if they are symptomatic or they feel that they're symptomatic, they shouldn't send them to school. Similarly,
okay, yeah, of course, we're not talking about testing of any sort. All right, so I think time to wrap up. So I'm going to allow each of you to perhaps just give a final message for about 2 minutes or so. Fiona, any comments from your side?
No, I just wanted to say, I mean, I think all of us, and that's probably why we struggle to get everybody on this meeting, we share concerns, we share, and on every single day we hear parents' fears, and it sounds like the pediatric community per se also has a lot of fear. So I think we have a responsibility as a pediatric community to spread accurate data and to put things in the right context so that everybody can understand it, and to see it as a relative risk, relative to other situations, relative to last winter, rather than this completely separate absolute risk that we've never dealt with before, because that helps to allay fears and that helps people to make rational decisions.
Thank you very much, Fiona. Shabir, you need to leave soon. Any parting words from you? I see you've been responding to some of the comments on the chat. I do apologize to participants for not answering the panelists, all your questions. There's been quite a lot, but at least Shabir has been answering some, so you can see his responses. But Shabir, some parting words from you about this whole scenario.
Yeah, I mean, I don't have much else to add. I'm just seeing some comments on this R0 and RT and effective reproductive rate. And the only thing I would caution against is one of the biggest challenges that we face with COVID-19, right, is the huge volume of data that's become available over a short period of time, most of which has not been adequately peer reviewed. And that's the reason we see a huge number of articles being retracted in the scientific literature. Right? And this is a time to understand that you need to be critical in terms of how you go about interpreting data. There's an article that you shared with me from Germany as an example, which indicated that children were as likely to be infectious as adults. And another group took the same data set and did a reanalysis and basically showed that those conclusions were completely wrong. Right? And we just need to be careful how we approach it, and we need to be measured. And at the end of the day, for me, we need to act in the interest of children. And right now, children are getting the short end of the stick in terms of the COVID response at the national level.
Thank you, Shabir. Mo, any last words from you? You just need to unmute yourself, please.
So I think I just agree with everything that's been said. And I think I think my last word would be, I think one of the issues that we haven't spoken about is the anxiety that's actually been left with children. Many children feel anxious about going to school and fearful of the consequences and other issues. So I think, as we discuss this, we shouldn't, leave students or children out of this, and also, discussing and encouraging parents to discuss these issues and having them to understand that they're not going to bring this infection and kill grandmother at home, which is a perception that's quite prevalent in social media at the moment.
Thank you, Mo. So to summarize, it seems like our panelists are quite, I would use the word belligerent, that unlike the South African public, unlike many of the teachers' unions, pediatricians, our panelists seem to have a different view and seem to be quite keen to get children back to school. I think what I've heard this afternoon is, firstly, that we know children are less likely to transmit, that They may pose a risk to teachers, they may pose a risk to their families at home, but that's not going to be an unduly high risk, recognizing that there's more data will certainly help. I think we heard from Fiona that there's actually very few categories of children that need to be automatically excluded from school. We heard about the usual cardiorespiratory conditions, maybe immunosuppressor, but generally the other groups, and there was a whole lot of other questions about pregnant teachers and what if my child is allergic, and I think none of those have come up as being strong enough reasons to keep children out of school. And then we had a little bit of discussion of the kind of worst scenario, that schools where many of these things can't be happening, whether it's social distancing, whether it's the hygiene aspects. And I think what I heard the panelists saying is that, in fact, despite that, they would still be recommending that children go to school, that it's less than optimal, but on a risk-benefit ratio, even in those suboptimal conditions, children are probably still better off at school. And then I think we had some discussion about how the school environment and individual children could be safe, and we heard some good examples about the kind of masks that are needed. Nothing extraordinary I heard, cloth masks, that social distancing is to be practiced as best we can, recognizing it may be difficult. But even if that breaks down, the overall view is that it's not as dangerous as perhaps many parents and certainly the unions think. I hope I've summarized correctly what our panelists say. I'd be happy for them to say, you got us wrong. But I certainly think it's the kind of approach we've presented this afternoon is saying, let's get on with it, which is not, I think, the current perception in the public. And there were some comments on the chat saying maybe we need to get our panelists onto national media to be saying these things and to be encouraging parents to go to school. I'm going to let Mignon give the final word, but I think what SAPA, the South African Pediatric Association, would probably should do and would hopefully do in the next 2 or 3 days is actually give a statement, a public statement about... Hey, Firdousa, then please put off your mic.
No.
Firdousa, please put off your mic. And I think it behoves us as the pediatric community to say what we think the evidence base is on this and to be able to give some set of recommendations. The Ministerial Advisory Committee clearly have got views, but those haven't been made public. And I would hope that based on today's webinar, we might be able to put a document together that says that. So as facilitator, I'll stop there and pass the baton back to Mignon in Cape Town. But to all the participants, the panelists, my deep thanks. They had other commitments that they didn't do. Thank you very much for a very informative session. And to everybody else who stayed on the course, the 300, thank you very much for being there with us, and despite our troubles, hanging in there. But perhaps Mignon can have the last word. Mignon?
Thank you, Haroon, and thank you to everybody. Haroon, this was your brainchild. Thank you for putting it together, and thanks to our panelists, really fantastic. I like your fan club. I'll dial in future, and we will try and increase our capacity next time. For those who missed it, we're hoping that our SAPA Facebook page will have this recording available. So just give us a day or two to get that sorted. And for those of you who received it by email, we'll try and forward it to you as well. But hopefully that was a very practical session. Thank you for supporting SAPA. Thank you to those parents out there. And I think we need to do what's best for kids. And that is what SAPA is all about, is striving for thriving kids. Thank you, everybody, and good night.